It's 10:01. Are we ready? Or we wait a few minutes?
I think
What
we
do you
give them,
think?
I think we give them a couple more minutes. People are still joining on. We have about,
Okay,
we have about 30 of 176 registrants that are joined on. So probably give them another minute or two.
okay.
No, that's okay. You can come in. I'm gonna. Oh, sure. Let me do that for you. Thank you.
Good morning, everyone. While we're allowing folks to join, if you would like to put your name, organization, and what you do in the chat so everyone will be able to know other participants on the webinar, that would be great. We have quite a few jumping on, so we'll give them just a minute for everyone to change over from a previous meeting and we'll get started. In the chat box is the CART link for those who need CART. And also, if you would put your name, organization, and what you do at your organization so everyone knows who's in attendance. Thank you very much.
It's 10:05. We have 74 participants in attendance. I think some more will trickle in, but it would be a good way to start. How's that, Dr. Elmer?
Sounds like a very good plan. Go ahead, Dr. Stitt.
Good morning, everyone. My name is Dr. Eva Stitt. My work focus is refugee mental health. I coordinate the Virginia Refugee Healing Partnership Program, which is a collaborative effort of the Virginia Department of Social Services, Office of New Americans Refugee Services, and the Virginia Department of Behavioral Health Developmental Services, Office of Behavioral Health Wellness. In today's presentation, I intend to cover, oops. Hold on, why is this not working? Okay, there we go. In today's presentation, I intend to cover the brief overview of Afghan SIVs in Virginia, the Virginia Refugee Resettlement Program, define some common terms and talk about language access. We will also discuss some prevention efforts, but most importantly, we would like to have a dialogue on needs and bridges to services, specific to behavioral health services. Before I proceed, I would like to introduce you to first my colleague in the field, Dr. Susan Elmore. Dr. Elmore, can you say hello to our participants?
Good morning, everyone. We're delighted that everyone could join us today and learn this important message from Dr. Stitt, and welcome. It will be recorded and we will be able to provide the recording to you later on. Also the CART transcription. Thank you, Eva.
Thanks. And also with us is Lauren Cunningham. Lauren, would you like to say hello and help us with these technology slides?
Sure. Good morning. I'm Lauren Cunningham. I'm the Director of Communications at DBHDS and very happy to be assisting with this important webinar this morning. Wanted to give a note about our stream text for CART transcription. CART is being offered in the stream text for those who are deaf, hard of hearing, or need words in visual format. You can see the link on the screen, and then Susan, would you mind dropping that in the chat as well for everyone? A suggestion, if you're opening the CART transcription, open it in a different browser than the one you have the Zoom meeting on, then drag to left, right, and create a split screen effect with the stream text on one side and the presentation on the other side of your computer screen. You can also do a split screen top to bottom if you prefer. A few instructions. Everyone will be in listen only mode until we reach the listening and discussion mode when we open for dialogue and questions. Please remember, as we said, we have real-time transcription. We recommend that you identify yourself before speaking, as well as your organization and the type of organization or area you are referencing so it can be captured. Please speak slowly and distinctly as internet speeds vary across the attendees. We will have a 5-minute break midway of our webinar. And I believe someone noted earlier, but this webinar will be recorded. And finally, just a few quick housekeeping notes. Please remember to mute your microphones when not speaking. If you're on the phone, please try *6. If you're receiving an echo, please mute either your computer audio or any ear listening devices. The echo should cease when only one speaker type is being used. Please feel free to introduce yourself in the chat with your name, organization, and type of organization so others in attendance will know the audience. I know a lot of folks have been doing that already. And please feel free to put any questions in the chat or save them to ask later in the presentation.
Okay.
I'll turn it back over to you.
Yeah, and if you're ready, we'd like to know about our participants. So we'd ask that you tell us a couple of things about you and your organization. And here we go. Okay, we'll give you about 30 seconds more. 72% has participated in this entrance poll. And wow, most of our participants are from the Community Services Board. Thank you for coming. 13%, 16% are from DBHDS. We have a big number from others. But we also would like to acknowledge the hospital or hospital association. Thank you all for these, for coming and joining us today. We appreciate it a lot. Okay, we can end the poll and here's the result. Thank you so much. Okay. let me, okay. Dr. Elmore, if you can take the,
Okay,
okay, thank you. So let's start with common terms. Common terms that will be frequently used in this presentation. My intent is that if we know about common terms and we know about the definition at the start, it could facilitate effective communication and it will put us all in one central focus. So refugee is commonly defined as someone who is unable or unwilling to return to their country of origin owing to a well-founded fear of being persecuted for reasons of race, religion, nationality, membership of a particular social group or political opinion. This definition was crafted in the 1951 Refugee Convention, facilitated by the United Nations High Commissioner for Refugees. And under the term refugees, there are different categories. There are parolees. These are immigration parolees, not the civil servants that violated the law. There are special immigrant visas. Currently, I just learned this, Afghans at risk. And then there are also asylees or asylum seekers, temporary protected status. But our focus for today's discussion is specific to special immigrant visas and those that are coming from Afghanistan. So even within this group from Afghanistan, there are immigration parolees, there are undocumented minors, there are asylees in there, but generally it's not for us to categorize. Let's just talk about and refer to them in general as refugees. So special immigrant visa holders are defined as individuals from Iraq and Afghanistan who help support the US contingent in its anti-terrorism efforts. So SIV holders are specific to these two countries, Iraq and Afghanistan. And limited English proficient is the word we use for individuals who do not speak English as their primary language and who have limited ability to speak, read, write, or understand English. And this definition is from the US Department of Justice Policy Guideline. Please note that either of these four, if an individual has limited ability to speak, they can be considered a limited English proficient individual. If they have limited ability to read, it's the same thing. They have limited ability to write, they're still considered limited English proficient. Or even if they know how to speak, read, or write, but they cannot understand English well, they are still considered limited English proficient. And I will explain how this relates to our topic this morning. So we ask, how come there are SIVs coming to the United States? Don't we have enough refugees? Well, the SIV program was authorized by the US Congress in 2009, signed by the then President Bush, the younger Bush. Prior to that, SIV visas were given to Iraqi nationals who supported our war efforts. But specific to the current situation, Afghans are eligible to SIV visa if they were employed in Afghanistan by or on behalf of the US government. They were employed in Afghanistan by the International Security Assistance Force, which means the US and its allies, to serve as an interpreter or translator for the US military. They have provided faithful and valuable service to the US government or the ISAF, and they have experienced or will be experiencing an ongoing serious threat as a consequence of such employment. I need not tell you much about what happened to Afghanistan because it's a general information now on TV, on radio, on press releases, it is there. So I need not describe you, but those coming to our shores, they had been one or all four of this. So what about SIVs in Virginia? What do we know? I just want to put this up front. These data are researched and not an official information from any entity. So I just did my little diligence, because if we are to put data, what I have researched last Friday would be different from today, and what I say today will be different tomorrow. So I leave it there as a fluid situation, and we'll pick up from what is recent based on press releases, based on official releases and things like that. So SIVs and families in Virginia are temporarily housed at Fort Lee, which has a capacity of 3,500. 7 of these are actual interpreters and translators. The rest are family members. So far, as of Friday, the total arrival at Dulles Airport was 8,600. 10% of SIVs will be resettled in Virginia. Most of them will be resettled in Northern Virginia and Richmond. If needed, and actually some of our SIVs from Dallas are already housed in Quantico Marine Base. They have a capacity of 5,000, and Fort Pickett down south of about 10,000 capacity. Now, the total evacuation from Kabul yielded 42,000 refugees. Why are they not in the US? It's because with international
Eva, you're muted.
Sorry, that's technology. I didn't touch a thing. I was saying about there are 3 housing sites at Quantico Marine Base and in Fort Pickett in addition to Fort Lee. Now, Fort Bliss and Fort McCoy in Wisconsin can temporarily house up to 30,000 SIVs together. This effort of resettlement and evacuation and repatriation may take years, even if the evacuation ends very soon. And what I know is that it ends today, based on the president's announcement. So what about the effects of war? We know that war does not end. The effect does not end when the war ends. So this study done by Clark about the psychological consequences of war trauma and post-social stressors, especially for women in Bosnia and Herzegovina, concluded that the long-term exposure to war and post-war stressors cause serious psychological consequences, with PTSD being only one of the disorders in the wide spectrum of post-traumatic reactions. Another study, it's still by Clark, they also concluded that post-war stressors did not influence the prevalence of PTSD, but they did contribute to the intensity and number of post-traumatic symptoms. Another study done by Lopez Cardozo in 2004, it was very specific to Afghanistan. And in the conclusion, it says that the prevalence rates of symptoms of depression, anxiety, and PTSD were high, and they need health planners to address the current lack of mental health care resources, facilities, and trained mental health care professionals in Afghanistan. But that was in 2004. Right after that, the war continues, and for 2 more decades. So that was way back in early 2000. I have 2 research here that was conducted last year and the year before. And Castro Valley says that the offspring of war veterans show increased psychological suffering as a function of their father's war exposure, intensity, but not their father's lifetime PTSD. These results could be used to suggest that mental health support for veterans' offspring should consider the war efforts and exposure, as well as the intensity of their fathers and not just psychopathology. These could spare offspring suffering if this mental health support could be delivered early on after war veterans return from war. And this is even if our SIVs, you know, migrated from Afghanistan to the United States, they will be showing the signs and symptoms, and children will be affected. Specific to children, it says that children in armed conflict areas in the Middle East experience high rates of mental disorders, including PTSD, depression, anxiety, behavioral problems, and attention deficit hyperactivity disorder, as well as functional impairment. Children must be supported in healing from the effect of toxic stress to break the cycle of violence in which the next generation struggles to rebuild society after the war trauma. So these children will be in our school system. They are not far and beyond the reach of the effects of this war. So the more prevention efforts we do, the easier will be for them as well as for us in the system. So given that, for you who will be dealing directly with SIVs in your communities, they will be there. They are here. Although most are resettled in Northern Virginia and Richmond, a lot of them are also around the different resettlement areas. So these are the different linguistic and cultural considerations. This is general and not applicable to all. But let me say, first we need to differentiate an Afghan from an Afghani. An Afghan is the person. The Afghani is the currency. So if I make myself an example, if you call me Dr. Stitt is an Afghani, then you are saying that Dr. Stitt is the currency, or Dr. Stitt is the dollar, which is not a good sentence, but also culturally it is wrong, because you don't call an Afghan as Afghani. If you refer to the person, call them Afghans, not Afghani. The other part that I would like to share with you is about the language. There are two main languages in Afghanistan, Fari and Pashto. Fari and Dari are the same language, but with different accents. That's how they vary. Of course, there could be some sentence construction there, but basically and technically, the words are the same. And Pashto is another language which is used by the eastern part of Afghanistan. So Fari and Dari are almost the same other than the accent. Pashto is a totally different language. And this is where I'd like to highlight this conversation as well. Arabic is not a language in Afghanistan. So when you talk to an Afghan person, do not pretend that they speak Arabic, because they don't. Although we have Dari and Pashto, there are other ethnic languages within Afghanistan. And these are Pashtuns and Tajik and Harazas. These are ethnics. And although they are small, we don't know how many of them came to the United States. Afghanistan is an Islamic republic with about 90% Sunni Muslims and 10% Shia Muslims, and less than 1% for others. What does that mean? That Sunni is a different religious groups than Shia Muslims. You just don't consider that because they are Muslims, they practice one and the same thing. because religiously they have different practices. Afghan culture and daily life has been significantly impacted as a result of persistent conflict, which started all the way back, over 2 decades of war. Another consideration is life in the urban areas is different from life in the rural areas. So you can see Afghans presenting to themselves at your door who might look different. Like it's not just like us, no head covers, using clothes like we do. That is very, very true. In urban areas like Kabul, for example, they are more modernized. But in the rural areas, they retain their traditional customs and including their way of dressing. So please note that not all people in Afghanistan wear traditional clothes. Some of them look like us because over the years, we have Western influence had also reached the urban areas, but not much in rural areas. The adult literacy rate is 43% compared to 84% on the international average. But please do not infer that Afghans are uneducated. In some way, many of them went to schools, others went to international schools, and we do have a lot of international agencies helping to rebuild Afghanistan. But all that ended today. Oh, sorry. The other part is that men speak English well because they were interpreters and translators, but women are not very well proficient in English. But what we have experienced with refugee resettlement is that even if the men speak English well, they may not understand the way we communicate our English here in the United States. So there is a cultural component that needs to be bridged, because when they were interpreting for our contingent, they are speaking in Afghan in English language. I don't know how that to translate very well, but in short, if I come from the Philippines and I'm not well versed in the American English, I'm speaking to you in my Filipino English. The sentence structure might be different, the words might be different, the terms might be different, but I thought I was speaking to you in English. Whether you understand the way I deliver my message is another thing to consider. So how do refugees come to Virginia? Do I make it too fast? I need to slow down? How is that? Does everyone follow? Show me some thumbs up or some feedback.
You're good.
Okay, thank you. So how do refugees come to Virginia? One, it starts at the federal level where the president makes a determination. So in the past, there was a year when only 19,000 refugees can be admitted to the United States. And then this year, it says we're going to have about 60,000 admitted to the United States. The processing is not direct. We go through the United Nations High Commissioner for Refugees. And in the normal process, there are 15 organizations, including the US Department of State, vetting for one refugee to come to the United States. But nonetheless, in the Afghan situation, some of them have been vetted. So they have this document that says they are SIVs. Some are in the process and they have not received it. Some has not applied yet. So that's where the big processing currently are in kind of very, very slow, because some have documents, some have been approved, but does not have the documents. Others have not applied, others are in the process. and all these other things. That's why it's chaotic as described by the media, because it is. So anyway, in the normal process, once the refugee is approved for relocation to the United States, they will be filtered through the National Voluntary Organizations, or called VOLAs. There are 9 of them. And out of that, National Voluntary Organizations, they will be filtered through the state. Okay, so now from the federal level, we go to the state level. So Virginia says, we take 2,000 refugees, which is our average. You know, since 1980, we take about 2,000 refugees a year. And that's our allocation. And then that is distributed to the different local resettlement agencies. The Virginia Department of Social Services Office of New Americans Refugee Services is the one overseeing this program. The contracts, the ONA, or the Office of New Americans, contracts with the VOLAG satellite office. And this is what referred to as resettlement agencies in Virginia. And they are the ones taking care of the refugee, starting from the airport, taking care of their needs such as housing, such as education, and all others. I will talk more about that later on. But what I'd like to show you is from federal level, there is a state level of how the refugees come to Virginia before they go to the local level. At the local level, we have local refugee resettlement agencies. There are 7 resettlement agencies in Virginia, but there are 9 resettlement sites. Okay? So the Virginia Resettlement Program, let's start at the state level, handled by the Virginia Department of Social Services, Office of New Americans Refugee Services. Here are down below are the resettlement sites. There are 3 in Northern Virginia. There are 2 in Richmond. There is 1 in Newport News. There is 1 in Roanoke, 1 in Harrisonburg, 1 in Fredericksburg, and 1 in Charlottesville. The resettlement program supports refugees with social integration and economic empowerment. They also support refugee eligible clients with support services like employment, health, education, youth mentoring, services for older refugees, and foster care for unaccompanied refugee minors. That's the resettlement program for the state. And how does trickle into the different refugee resettlement at the local level? The refugee resettlement are the one providing direct services per contract with the State Office of New Americans. And where does the Virginia Refugee Healing Partnership belongs? We are neither part of the Virginia Refugee Office of New Americans, nor part of the resettlement. But what I do as coordinator for the Virginia Refugee Healing Partnership is provide support specific to refugee mental health. That's why with Dr. Elmore and I, we thought that this is the best way, putting this webinar so that we can develop prevention measures before things get serious and we will be dealing with individual cases at the local level. And I hope we will be successful in presenting this to you in a way that we can collaborate in a lot of prevention measures, and you can tell us what support you need so we can help the refugees. So the Virginia Refugee Healing Partnership is a collaborative effort of the Office of New Americans and the Virginia Department of Behavioral Health and Developmental Services, Office of Behavioral Health Wellness. My director is Gail Taylor. The Office of New Americans have 2 different programs, one for immigrants and one for refugees. Although I deal with both, but my focus are the refugee services. And when we created the Virginia Refugee Healing Partnership, or VRHP, we plan to establish sustainable public-private collaboration to ensure that refugee access to behavioral health care are being put forth in front. We also would like to develop pathways to support behavioral health providers prepared to serve refugees. And we would like to strengthen refugee mental wellness and capacity building measures. And this we can do with collaboration through a statewide strategic effort, working with CSVs, working with DBHDS hospitals and facilities, working with the different refugee resettlement and other volunteer organizations that are helping and supporting the refugees, be it at the state level or at the local level. Some of the voluntary organizations are helping us with webinars at the national level. So we can do a lot, but we need to collaborate. And this webinar is our way of reaching out to you. What can we do together? We have done a lot of prevention efforts. If you can see the list here, we do a lot of training, we do a lot of webinars, we conduct conferences, but we know that is not enough. So there are still a lot of spaces of what we can do, represented here by question marks, right? So we will work on and talk about how we can do this together, but I think we have used about 30 minutes. I want you to listen to me. I want you to be well awake. I want you to be receptive. So why don't we take a 5-minute break? That way we get refreshed when we come back. We will be back at 10:40. How's that?
Sounds great. So everybody can take a break and take care of whatever you need to do. We'll check in at 10:40.
Thank you, Dr. Elmore. $11:40. We're back. Oh, it's 10:40. Sorry, I'm an hour ahead. 10:40. Hope everyone is back. We will continue our discussion with language access and behavioral health. Why is this place up front? Because if you remember, I talked about many of these Afghan SIVs speak Dari, Farsi, or Pashto. Okay, and someone called my attention. The ones I earlier mentioned, like the Pashtuns, they are ethnic groups. They are not languages. So I work on that later on. And I'm talking about, let me just go back here on my screen, and it says, Pashtun, Tajik, and Hazaras. Those are the words. It was a typo. These are not ethnic languages, but ethnic groups within Afghanistan. Some of them are resettled here in the United States as part of this massive evacuation. So why am I bringing language access? Because not all of them speak English. And once again, I would like to emphasize that even if they speak English, do not believe until you have proven that they read, write, or understand English, because these four are the components of effective communications. Okay, so language access services or language assistance services are written and oral services that agencies use to bridge the communication barrier with individuals who cannot speak, read, write, or understand English, so that they can access the services in the same way as those who can speak, read, write, or understand English. In the words of the US Department of Justice, it says, recipients have two main ways to provide language services. Recipients being us, recipients of federal money. We provide oral and written language services. Quality and accuracy of the language services is critical in order to avoid serious consequences to the LEP person and to the recipient. This definition was done all the way back in 2002 and is still being used and referenced today. Now, although a lot of us are still using the word client, patient, or consumer, we would like to encourage to use the word individual to replace the term client, patient, or consumer. This is stated in the Virginia Code. And I would repeat, individual is a new term replacing the previous definition of a client, patient, or consumer. Interpretation. Interpretation is the act of listening to something in one language, which is our source language, and orally converting it into another language, which is a target language. So in interpretation, a source language is, for example, there is a Dari speaking client. When an interpreter interprets the Dari into English, the source language is Dari and the target English is English. However, if the interpreter interprets the English message, the message in English spoken by the clinician into Dari, then the source language become English and the target language become Dari. So the source language and the target language is not does not define, like saying the source language is always the foreign language and the target language is always English or vice versa, because it depends based on how the messages are converted from one language to another. Of course, we know that the person doing this interpretation is called an interpreter. And according to the National Council on Interpreting in Healthcare, which is a national organization for interpreters, we define that as the interpreter being a person trained to convert oral messages from one language to another. I would like to highlight the word oral because interpreters don't do written transmission of messages. And interpreters are kind of defined in different ways. Ad hoc interpreters means untrained interpreters. They could be family members, they could be friends, they could be anyone in the staff who is not trained. They're all considered ad hoc interpreters. In the behavioral health training that we offer, that we are training bilingual staff interpreters. And bilingual staff is self-explanatory. We are training DPHDS staff, refugee resettlement staff, voluntary organization staff, members of the refugee mental health councils, any individual who belongs to an organization and who wants to learn and be trained as behavioral health interpreters, we offer the training, and in the end, we call them bilingual staff interpreters. It's a 24-hour program. The other one, which is an expanded form and parallel to medical interpreters, we call them behavioral health interpreters. We offer a 40-hour training specific to interpreter in behavioral health settings that covers mental health, substance use, and developmental disabilities. Why is ASL not included? Because ASL is a world of their own. And besides ASL interpreters, have the Virginia Department of Deaf and Hard of Hearing who are taking care of this. In short, simply means they are way advanced than us, than just medical interpreters, behavioral health interpreters, educational interpreters, court interpreters, community interpreters, and all other kinds of interpreters, because the ASL interpreters are more controlled for their quality service. The other part is we call certified interpreters. Certified interpreters are certified by a national body. And for medical interpreters, we have two certifying bodies. That one called CMI, conducted by Massachusetts, and the other one is CHI, conducted by California. So only two are known for health interpreters. ASL interpreters have their own certification program. So medical interpreters and ASL interpreters can be certified interpreters. But let me tell you this. In the behavioral setting, some of these certified interpreters may not be qualified to interpret. And I will tell you why shortly. Just know that not all certified interpreters are qualified to interpret in behavioral health settings. Who are competent interpreters? Competent interpreters demonstrate proficiency in and ability to communicate information accurately in English and the target language. Competent interpreters have knowledge in both languages of any specialized terms or concepts peculiar to the entity's program. So this is one of the reasons why I told you that a certified medical interpreter or a court certified interpreter may not be qualified until they know in both languages special terms or concepts peculiar to behavioral health. Also, competent interpreters have knowledge of any particularized vocabulary and phraseology used by the LEP person. And competent interpreters understand and follow confidentiality and impartiality rules to the same extent the recipient employee or our employees for whom they are interpreting and to the extent their position requires. This letter D is very important. Confidentiality, we even have a specific law, HIPAA, on confidentiality. But an untrained interpreters or an ad hoc interpreters may not know about confidentiality and impartiality in the context of interpreting. That's why we offer the Virginia Behavioral Health Interpreting Program using the Virginia Behavioral Health Interpreting Curriculum. It's a validated curriculum that is now, for the past 3 years, we have been using to train behavioral health interpreters so that they are qualified and competent to interpret in behavioral health settings. So what about our bilingual staff? Bilingual staff offers one of the best and often most economical options if they are competent in the skill of interpreting. And these are not my words. This is not what DBHDS said. This is a policy guideline from the US Department of Justice. So bilingual staff we can leverage the skills of bilingual staff, but just know that being bilingual does not mean competent to interpret. And if we do have a bilingual staff, we follow a single role approach for dual role interpreters. What does that how does that happen? When, for example, a case manager who is a trained behavioral health interpreter can interpret for a clinician. Now, that case manager is sitting in the role of an interpreter and will not use his or her role as a case manager in that interpreting session. So we say, to avoid conflict and confusion, use the single role approach for dual role interpreters. And because in order to ensure that there is no issues between the system and the bilingual staff who are providing services, the US Department of Justice policy guidelines says that we need effective, appropriate management strategies, including any appropriate adjustments in assignments and protocols for using bilingual staff. Some of the CSBs have already a plan for these, such as, it's a written plan, not just an agreement between a supervisor and the employee. And so it means it can be done. And I'm hoping that some of you who does not have a guideline on how to use trained bilingual staff, not just someone who speaks another foreign language, but a trained bilingual staff, to have some appropriate management strategies and appropriate adjustments in assignments and protocols so they can be used to help support language access within your organization. The other part is that bilingual staff does not mean they are competent to translate documents. Unless they are trained translators or certified translators, they should not be used to translate documents. Long documents, short documents, they just should not be used. However, if they are native speakers of the target language, they can review the material to ensure culturally appropriate languages. When I say review the material translated through a professional translator or through a translation organization. And know this, the certification of translator is by language pair, not with skills. So if I claim to be a certified translator, what is my language pair? Maybe I would say Tagalog and English, or others would say Spanish and English. Others would say French and English. But I cannot claim to be a certified translator in all the languages that I know and in all the languages that I speak. So practically, even if I speak 4 different languages and 3 different dialects, maybe only 1 or 2 of these are certified. Why? Because there are not a lot of certification tests in all languages. It's very limited. So if you ask for a certified translator, even with these different language service providers, please ask, what is the certification of your translator? Example, if you are talking of Pashto or Dari, there is no certification for that. There is no certified translator because there is no test for Dari and Pashto. Therefore, it's useless to say, I want a certified translator in Farsi. It will not happen because there is no certification test for translator in Farsi or Dari. If you say Spanish, the answer is yes. If you say French, yes. Russian, yes, but not the languages of lesser diffusion. So what do? what do? We ask native speakers. We ask native speakers, but that doesn't end all. One person translate, the other person will review, because there is a lot of considerations why we do what we do. It's called back translation. So what is translation? So interpretation is oral, translation is written. A written text from one language to another. But sometimes when we do translation, it could be done by certified professional based on the language that we want it to be translated. Sometimes translation can be done by non-certified professional, especially if the language is a language of lesser diffusion, or simple words, rare language. The other part is site translation. Although this is part of interpreting, I put it here so as not to confuse you. But site translation is something like a postcard or a flyer, which you can show to the interpreter and say, can you please site translate this so that the LEP individual is able to understand what's in this flyer or what's in this postcard, or what services do we offer. So something small, something like within reasonable time, and give them a brief moment, maybe 5 minutes, 2 minutes, depending on the length of the material, so that they can read it and translate it accurately. It's not how fast, but rather how accurate is the translation of the messages from one language to another. Machine translation, I've seen a lot of organizations doing these, but please do a back translation. You will be surprised. When the Spanish, when you back translate, it's about 90% accurate. But with other languages, you will be surprised. What is back translation? So you put it on a Google or other forms of language translation, and then put your sentence. And then it will be translated to the different language, right? Your target language. Example, let's say from English, I want it translated to Dari. From Dari, copy that translation and put it back and ask the machine to translate it in English. Sometimes it's about 80%, sometimes it's about 30%. Sometimes it's totally different when translated at all, because Google Translate or other forms of translation devices are not attuned to translation in languages of lesser diffusion. So please, when you do translation, especially for a public document, have it read by a native speaker. I mean, I'm not saying this to let me translate that. Let me rephrase that. Not long ago, the Virginia Department of Health provided a translated message from English to Spanish, right? And they have it translated in some other way. And then they send it for public release. Boy, oh boy. When the Spanish population read it, instead of saying, please get your COVID vaccination, it says, you don't need COVID vaccination. Totally different. So what happened then? It took them a lot of time and effort to say that what we mean is this. We don't need to have that happen. Just ask for a back translation. Let it be read by a native speaker, because culture plays a part in how messages are coded and decoded, how messages are understood. We thought it is this way, but for them, it is read and meant this way. And we don't want that to happen. We want the messages translated accurately from English to the a foreign language. Now, this translator is a person with formal training and extensive background to convert these written texts from one language to another. So someone with no background may not be able to understand about tone, about register, about cultural nuances, even the culture of your organization as a behavioral health care facility. All these are considered in a formal written translation of a text. Let me move. This one is transcreation. This is not normally presented in our training for behavioral health interpreters. It's because transcreation focuses on conveying the same language, the same message in a different language. Example, posters. Posters can be transcreated, not translated. Transcreation means that we say the same message, but a new language might be more meaningful, such as, example, marketing materials, posters, and other documents that requires the reader to take action. So we use transcreation for messaging, but translation is what we need for vital documents. So language access are very important because it has possible consequences to the agencies and organizations, to individuals, and to our funding. And I need not tell you much about that, but of course, if you don't comply, there are penalties and fines. There can be lawsuits, there could be award payments and closure of facilities. For individuals, we might be having inaccurate diagnosis, some treatment delays, longer hospital stays. For funding, it's really, really important because we don't have unlimited resource. Every dollar counts. And so the more effective we are, the better it would be. Let me just tell you two stories. One, we have one person in our state hospital who just need a restoration order, but he stayed in our facility for 7 years waiting for that restoration order because no one is there to interpret. 7 years. Think how much money we have spent for this individual alone, because we are not able to provide language access, or we are not able to access, or whatever be the reason. Unnecessary stay cost us money. The other part I will tell you is that we have one person, she went to an emergency room. She's pregnant, she has a 4-year-old kid, but she went to the emergency room because she had stomach problems. She has stomach pains. In short, when the lady said, the individual said that I would, something that kills, is she said, let me phrase it well, I will die. I will die for my kids to keep them safe. And because the person who is a bilingual staff pretend to interpret in that ER, it was interpreted to mean I will kill my children. Instead, I will die for my children. It was interpreted to say I will kill for my children. And so Friday as it is, the adult services was called. She was brought to our facility. She stayed there for Friday, Saturday, not until Monday when they have our clinician who understand language access, had they found out the real truth. That individual has missed taking care of her daughter, left with a neighbor, and she got all this kind of treatment in our hospital on Friday, Saturday, Sunday, and Monday before it was clear that this individual said, I will die for my children, not kill my children. There's a big difference. That's how she came into our system. Still, it's a very brief story, but I'm trying to emphasize here that not having an interpreter costs us more in many circumstances. These are the different language legal basis for language access services. There are federal level, there is one executive level, there is the Virginia State Board Policy 1023, and there is DBHDS Instructions 209. I will skip that. You can see this later. I will send the PowerPoint to all the registered participants. The other part is that these are our language access efforts and resources. But prior to having this, I mentioned that we have webinars for clinicians. There's one scheduled for September 17th. I will send you the flyer. There is a behavioral health interpreter training every month. There is a language access conference. We conduct 4 a year. There are webinars for interpreters. There are information materials and more. We do that at the Virginia Refugee Healing Partnership with a hope that we can disseminate information and met our target by which this program was created. So real quick, I would ask Dr. Elmore to talk about access and functional needs, and then we will go to facilitated discussion. Dr. Elmore?
Yes, can you hear me?
Yes.
Thank you, Eva. Access and functional needs, and that's one of the areas that I do at DBHDS, includes, and you've heard this many times, of working emergency disasters and COVID, access and functional needs, sometimes referred to as vulnerable populations. There are 8 population groups which are specifically under that. So it includes physical disabilities, mental disabilities, LGBTQ, limited English proficiency or the ESL, persons experiencing homelessness, pregnant women, refugees, and older adults. And so what we do on that is, if there are things that we need to network or resource, we do have that in the Commonwealth, and there's a whole group of us spread across the state agencies. So that's kind of my role here, is to support Eva on the mission with refugees. So thank you, Eva.
Thanks, Dr. Elmore. And this, I would ask Ms. Cunningham to help us facilitate the dialogue. And of course, Dr. Elmore is there as well, looking at the chat and all the questions and putting us in order. This is the core of why we have this webinar. We hope to have a dialogue with you on needs and bridges to services. What I put in here are the different groups. Of course, we have the state hospitals and facilities, but these other highlighted areas are sites where we have the different refugee resettlement. For example, in Northern Virginia, we have 3 of them. In Roanoke, we have 1, Harrisonburg 1, Fredericksburg 1, but Richmond, we have 2, Charlottesville 1, and Newport News. But know this, example, in Roanoke, although the main agency is in Roanoke, we are resettling refugees in Blacksburg, as well as Salem and neighboring counties. For example, in Richmond, we're not just in the city of Richmond, we're also resettling refugees in Hanover and Chesterfield and other parts, neighboring parts in Richmond. So there are 3 important questions we would like to solicit your input. First is practical considerations. The other are identifying possible gaps, and other is resources that we can help you provide trauma-informed care to SIVs in your locality. I would like to ask Ms. Cunningham to facilitate this. If you are ready with your questions, or you can put it in the chat, we'll see. Lauren?
I'm here. For the facilitated dialogue, please remember to use the raise your hand function and we'll call on you. And of course, you can also put questions in the chat. We want to hear from you and know where supports are needed. If you just please remember to identify yourself with your name, your organization type, i.e. acute hospital, a DBHDS operated facility, or a home health agency, as well as your organization name. And with that, I think we're ready to go. Question number 1. What practical considerations does your organization need to make behavioral health accessible to Afghan SIVs?
Feel free to unmute your mic or raise your hand. If you're on the phone, you can use the *6. And just to start off, one question, Eva, that I saw, or Dr. Stitt, that I saw in the chat was, how can organizations access services? So, you know, like the CSBs and the DGS contracts, how can organizations access those interpreter and translator services?
Oh, thank you, Dr. Elmore, for mentioning that. Specific to behavioral health interpreter services. For the moment, I have the list of those who have completed the behavioral health interpreter training. I have the list based on who are within our agency, who are based in the different CSBs, and those who are from the general public. But we are hoping, and this is a project of the Office of Behavioral Health Wellness, that we will hire a coordinator whose work is focused on language access to make it all accessible to you. My director, Gail Taylor, will provide us with comprehensive information on how this could be done, but it can be accessed. I think the Office of Behavioral Wellness can frame this in about a month or 2. For the meantime, just email me at vrhp@dbhds.virginia.gov if you want to know who among your bilingual staff have undergone the behavioral health training. Does that answer the question?
Yes, and I see Stamar. You can unmute.
Hi, Dr. Stitt. Hi, everybody. This is Samar Helmstutler with Fairfax County Community Services Board. This is more of a suggestion and sort of learning from the things you've done around the state before. I was wondering if there could be a possibility for identifying cultural and language experts who are both experts with the language and cultural issues, as well as behavioral health stuff, such as social workers or counselors, psychologists, and psychiatrists around the state who will sort of be identified as a resource for people who are basically coming across certain kind of situations, to have that resource to call and consult. I think at this point, considering SIVs versus the refugees that we've had in the past, this is a different kind of situation in my observation, maybe because that, like, the situation happened very rapidly. So the behavioral health impact, the trauma impact, and just the resettlement altogether is a little different because of the timeliness of it. So I think you sort of need to be on the lookout for the situations that will rise. But one of the things I've seen is that it would be helpful to know there is this sort of group of people connected to state that.
Do we have other feedback or input regarding practical considerations from our participants? Annette? Annette, please unmute.
Hi, sorry. I'm Annette from Centera RMH. And I was just wondering, are there any, if there are some individuals who might have difficulty as far as affording medications post-hospitalization, are there any programs for them, or would there be any?
SIVs are considered refugees, and they will have insurance up to about 9 months of their stay, because we are hoping that somewhere in the process, within 30 to 90 days, they could have jobs, and they can pick up their insurance from the employers. But generally, refugees have up to 9 months of insurance, unless they are kids where it could be extended, you know. So, but generally, that's we are. For adults, that's what we can hope for. But more than that is something of a gap in service. And we have brought that to the attention of our upper leadership. I do not know the answer.
Okay, do we have any other questions before we move on to question 2, or any other thoughts? All right, I think we might be ready for question number 2. What are possible gaps in behavioral health services for limited English proficient individuals? And again, remember, just go ahead and raise your hand and come off mute, and we'll take your questions.
Is there no question in the chat?
I see Melissa's added to the chat. There's income-based prescription drug programs through manufacturers.
Okay, thank you, Melissa. Thank you. That helps. What about gaps in services? I mean, we are talking about your own organization at the local level, especially at the CSBs. Well, probably not just that, because also we have gaps in services for our state hospitals and facilities. But we also understand that each CSB has their own programs and resources, and not providing the same service across the board. So we'd like to know what possible gaps in behavioral health services with limited English proficient individuals have you identified within your system? Because with that, we can formulate probably a better way of responding. And if we can provide support in specific areas where you have identified to have gaps, we don't know that until we get your feedback. How can we help you? What are the possible gaps? You can unmute, raise your hand, or put it on the chat.
I did notice in the chat, someone dropped in a link for some resources, so that'll be helpful if you want to make sure to click on that before it falls away.
Okay. Okay, so we have resources provided by one of our participants. Okay, you can click the link, or you can copy the link. And because this webinar is recorded, it will be shown in the transcription. Okay, if this is too hard a question, let's move on to the next one.
All right, question number 3. What resources and services are currently available in your organization that can support trauma-informed care? And again, remember, just raise your hand and come off mute, and we'll see who has what.
Hi, my name is Freshta Tayeb, and I am the Senior Refugee Interventionist at Cornerstone Family and Marriage Intervention. I am the lead Dari speaking interventionist there. So we are happy, our organization is happy to partner with anybody who requires this service. So I have my information in the chat box from the beginning. I put it in there. Please do reach out, and I'll be happy to further that partnership. Thank you.
Thanks. There we have other volunteer organizations. We'd like to hear from you. How can we reach you? How can we work together? Are there resources and services that we can help support you? Or what are resources and services currently available in your organization? It's nice to know. Nothing on the chat. Anyone can unmute. 2 participants raise hand, and we can take Valeria. Valeria, please.
I'm actually Sharon Schlurf Newcomb on Valeria's link because she reached out to us. We're actually military specialists in trauma care. So in terms of what the resources are currently available, we are behavioral health services with SAMHSA and with federal programs that deal in the trauma care with both refugees and our own service members. So in terms of the biggest concern from our part, I would say is that we do a lot of peer support. And so we would be linking our military specialists here, service members, with these SIV, Afghan SIV members, so that they have a commonality in being able to connect, because they may have served with them in the past throughout this 20-year conflict, or we might be able to adjust also with the families because we have the same similar situation in caregiving.
Thank you. Can you say your name again in your organization? How can we reach you?
My name, I'm president and the clinical provider and trainer for this. So it'd be Sharon Schlurf Newcomb. And our actual organization does business as Beacon Institute Veteran Pathways Home. And we are located in Williamsburg, Virginia. We serve all of Virginia for military support.
Oh, great, great. If you can just put the link on the chat, that could help a lot of our participants.
I will do
Any
that.
other, any other feed? Oh, Annette, sorry, Annette. Annette, you can unmute now.
I never put my hand back down after the last question, sorry.
Oh, okay, sorry. Okay.
We do have something in the chat. Is there a plan to enlist faith organizations to help establish trust and fill knowledge gaps in the individuals arriving here to provide an understanding of what the services are and the benefits to them?
That is a really very good input. We were thinking about faith-based communities at the local level, but I think the Virginia Refugee Healing Partnership can tap the resources at the Office of New Americans. But I would like to follow up this conversation with an email. If you want to help serve the community, either as a faith-based organization or behavioral health organization, I would like to gather that information so that I can resend it to all. So in short, I will try to gather that and send it to everyone. But for me to do that, I will send you a separate email as a follow-up of this webinar. Thank you for that input. Is there
any other questions? Remember, just raise your hand and we'll ask you to come off mute.
Okay, it appears like we're tired. Probably we're just about ready to leave. We have 3 minutes before our closing time. If there are no more chat for this particular question, or no one is ready to speak up, let's get to our next slide. How's that, Lauren?
That sounds good to me.
Okay, so let's get our closing poll. Okay, the closing poll is here. It's anonymous, so just be honest. Have you learned very good in this webinar? Or did you have good information? Or was it so low that you were not able to ask your questions because you got understand nothing? So here we are, just be honest, tell us.
While you're doing the poll, if there are other areas you would like Eva to do training on or webinars on, or for DBHDS to do webinars on, please put the topic in the chat for us and we will try to capture it, because there's much more to be done. If there's a service that you are doing, if you're having groups or support groups for any of the family members or any different groups that you might be having or starting, be sure to let Dr. Stitt know. Looks like we've got 73% that are still with us or on the computer that can answer. So I will end the poll now and let's see if we can share results. All right, Dr. Stitt, can you see that?
Yeah, sure. Well, a lot of our participants, especially those who responded, said that they received good information, and 35% said we have presented very good information. So in total, that is 83%, means that they had benefited from this webinar. And none said it's low, but there's still a 17% that says somehow it was not really meaningful, probably, or important. But anyway, what we got from here, we will transcribe it into a more strategic approach, so we are able to collaborate with you and, if possible, support you in ways that we can serve our SIVs, especially on prevention matters. So without much ado, it's 11:30. Thank you so much. We also would like to acknowledge Dr. Elmore for being with us and who is instrumental in putting this together, and also Ms. Cunningham, who had been so good in helping us with technology and facilitating our discussions. To all of you, thank you so much. And here's the contact information. Here's the contact information. And if you want specific to the Virginia Refugee Healing Partnership Program, you can email at vrhp@dphds.virginia.gov. Thank you, everyone. Bye.